He has done his DNB Family Medicine from Sargangaram Hospital, postgraduate diploma in HIV medicine from Maulana Azad Medical College, fellowship in diabetes from CMC Belur. He was he was senior resident at Sargangaram Hospital and also at Deen Dayal Hospital, Delhi. He has several published articles in his name, more than 20 papers in his name. He has also more than 50 oral presentations. He currently chairs the Rural Health Group of South Asia, Wonka Rural South Asia, Warsha. He is advisory board member and two an executive member of World Organization of Family Doctors. So, Dr. Pratyush, I invite you for your talk on diabetes and infection. So, Dr. Pratyush, please.
Thank you, sir, for your kind introduction. And let me share the slides. Okay, so like today we are going to talk on some very important topic, and that is uh, infectious diseases related with diabetes. And it's important because recently we had a COVID pandemic, and we have seen lots of our diabetic patients going into some severe complications because of diabetes. And through this presentation, we'll come across different aspects, pathogenesis, and how to detect those kind of infections with diabetes, and what are the newer treatment modalities, how we can detect and prevent. So coming to the slides proper, and this is the basic disclaimer. So basically what we are going to do is we are going to understand the overlap of diabetes and infections associated with to understand various infections that are more common in persons with diabetes, to understand the impact of COVID 19 and infections in persons with diabetes. And obviously, we will talk about the impact of mucormycosis, which is one of the hot topic in the recent past few months, which is commonly called in public domain as black fungus. So the first basic question is why patients with diabetes are more prone to infections? Why patients with diabetes are more prone to infections like mucormycosis, candida, lungs infections? The most common region what's being postulated, what's being spoken is our immunocompromised state. Because of raised blood sugar levels, patients go into some kind of immunocompromised state, and that promotes infection, spread of infections. Uncontrolled hyperglycemia gradually lowers overall immunity, and there are different pathways through which it involves. Plus, the hyperglycemic environmental factors, environmental favors immune dysfunction such as damage to neutrophil functions, impairment of antioxidant systems, and humoral immunity. High blood glucose levels, it impairs both innate and adaptive immunity, and chronic hyperglycemia can result in acidosis, which reduces the activity of immune system. It virtually affects all our body systems. Skin and soft tissue like diabetic foot is one of the most common presentation. Necrotizing fasciitis, farnius gangrene. When you talk about the gastrointestinal tract and liver infections, but the most common impact of diabetes is autonomic dysfunction, like patients presenting with dyspepsia. But when we are considering infections, H. pylori infections leading to acid peptic diseases, repeated patient comes with complaints of bloating, repeated infections, a pain abdomen. These could be because of H. pylori. Candida is one of the most common things, which is widely called as white fungus. Apart from that, some of the rare complications could be emphysematous cholecystitis. The hepatitis B and C is basically it's a blood-borne, but in diabetes the complications may increase. Intravirus is another virus which leads to diarrhea and other gastrointestinal manifestations. Respiratory infections are one of the common presentation, patient presenting with pneumonia, it could be because of influenza, swine flu, or tuberculosis. But very good thing which I would like to focus here is that we have got vaccines for influenza. All diabetic patients, they should take at least vaccines for influenza. It's an annual vaccination is there, so that they can prevent influenza attacks every year. For pneumonia, there is a vaccine which once in a lifetime they need to take, and beyond the age of 65 years, we give a boosters. Pneumococcal vaccines is already there in the national immunization program. So those kids who are growing up, they obviously might have taken pneumococcal vaccine, but our older patients, those who come up, that's the time to counsel them to take for vaccination for influenza and swine flu, uh, influenza and the pneumonia vaccines. Tuberculosis, obviously, there is a vaccine available, but it's not very much effective. Regarding UTI, females usually have this common complications of UTI, urinary tract infections, but in diabetes, there could be fungal cystitis, emphysematous cystitis, bacterial pyelonephritis, and perinephric abscess. When you talk about head and neck infections, there could be infections in the ear, it could be external otitis media, it could be invasive, and with COVID, we have seen some more dangerous and more complications with rhinocerebral mucormycosis. This is one of the studies which are published recently in 2017 and 2020 regarding prevalence of infections in persons with diabetes. And one of the most striking things you'll see here is that out of 10 patients who come to our OPDs, almost 4 out of 10 have got soft tissue infections, 3 out of 10 is having a respiratory tract infection, and 3 out of 10 will also have a UTI. So this is a very significant prevalence of infection in diabetic patients. And if you look at tuberculosis, which is very common in our state, almost 5%, like out of 100, uh, you may find 5 patients out of 100 of diabetic patients suffering from tuberculosis. So complications of diabetes usually favors infection. Uh, Obviously, there are microvascular complications and macrovascular complications. Microvascular complications like neuropathy. If patients, when they develop neuropathy, there is no sensation of food coming from foot and hand. There could be, if there is associated vitamin B12 deficiency, then they can go on for glove and stocking kind of anesthesia. And when there is neuropathy, there is more risk of developing ulcers, and if not treated early, if not managed aggressively, then it may further lead to diabetic foot. So, neuropathy in combination with peripheral vascular disease, which is one of the macrovascular complications, it may lead to ulceration, skin, and secondary infections. If there is defects in innate and adaptive immune system, then obviously there is an increase in the risk of infection. So it is said that every 1 millimole per liter increase in plasma glucose is associated with 6 to 10% increased risk of hospitalization for pneumonia, UTI, and skin infections. So 1 millimole is something around 18. So if your blood sugar is going around 200, then obviously the risk is going much more, like it's much more than 10%. Dialysis and lifelong immunosuppression post transplant is associated with increased risk of bacterial infections. Poor glycemic control has been shown to be an important risk factor of infections. Diabetes associated infections, if we look at its pathogenesis and development of antimicrobial resistance, uh, this is one of the most important things which we need to understand, that not every patients who come with a fever, cough, and cold we should prescribe antibiotics, because nowadays what we are seeing, there is a growing evidence that antibiotic resistance is rising up, and it's only because of indiscriminate use of antibiotics, over the counter availability of antibiotics, and that may have its own long term side effects. And if you look in diabetes, there is incidence of neuropathy and angiopathy is there. Antioxidant, uh, oxidative stress is actually more in cases of diabetes mellitus. The T lymphocyte response is decreased, and there is a decreased neutrophil function is there. There's decreased secretion of inflammatory cytokines. Humoral immunity disorder is there. Hyperglycemia. It leads to increased virulence of microbial infections. And there's large number of medical intervention that what is called as polypharmacy. Patient taking multiple drugs and each has got its own interactions. And we need to be careful while using antibiotics without testing it. Surgical site infections. Usually before surgery, all the diabetic patients needs to get clearance because there is much more risk of surgical site infections, and that is more common in cases of cardiac surgeries. It's 22.4%. After every spinal, there is increased risk of surgical site infections, and it's because of poor permeability, poor glycemic control. These also aggravate such kind of infections. So, one of the common questions which we need to ask ourselves that is there a need of comprehensive guidelines with respect to Indian patients to tackle with diabetes associated infections? And obviously, we do need some kind of guidelines so that all the use of antibiotics could be streamlined. So, there is high risk of morbidity and mortality due to COVID-19 infection in persons with diabetes. And if we look at the regions, the pathogenesis which we talked about recently, that there is a dysregulated immune response. Our immunity is not working so efficiently, and that's what leads to increased risk of infection. So one problem is there with our existing immunity. Second problem is if you talk about our chest problems, lungs problem, there is alveolar dysfunction. There is problem with endothelial dysfunction and coagulopathy, which may lead to angiopathy and macrovascular um, complications. And obviously, with coronaviruses, the coronavirus load was high. There was something, the ACE2 receptors. Um, uh, there was much more replication of coronavirus, which is seen with diabetic patients. So, COVID 19 outcomes according to pre existing diabetes, multiple studies, Zhang et al., Kumar et al., they all have shown that the risk is much more higher in cases of diabetes. And it was the patients which were taken into this study, sample size was good enough 16,000, 1,500, 5,279, 258. There's significant number of sample size. So, there's less chances of these risks being altered or being modified. So, what we have seen with diabetes and COVID 19 is that one of the most potent treatment and one of the most effective treatment in COVID 19 was use of steroids and basically revolutionized in a way the COVID 19 treatment in second wave and also help to many patient come out of ventilator, come out of ICU. But it also has its own side effects. That's why we call it as double-edged sword. So steroid therapy led to secondary bacterial infection, invasive fungal infections, and also affected the morbidity and mortality. So steroid has its own benefits. It also has its own side effects. Steroids leads to uncontrolled diabetes mellitus and plus other immunosuppressive conditions including corticosteroids that further aggravated the conditions and promoted use of invasive fungal infections. So these mucormycosis, what we are talking is mostly of rhinocerebral, which was very common in cases of COVID-19, and the common signs and symptoms was pain and redness around eyes or nose. Fever was there, it was high grade fever, headache, coughing, shortness of breath, bloody vomits, altered mental status. These were some of the common presentation in patients coming up with mucormycosis. If we talk about different types of mucormycosis, rhinocerebral, which affects us brain and sinuses, pulmonary mucormycosis, that is very much common in cases of transplant recipients, gastrointestinal mucormycosis there that proliferates when we take more iron, Cutaneous mucormycosis, it spreads when there is any kinds of break on the skin and disseminated in cases of immunosuppressed patients. We see disseminated mucormycosis. Transplant recipients, those who are on immunosuppressive drugs, cancer patients. So rhinoorbital cerebral mucormycosis, there's a fatal complication of uncontrolled diabetes mellitus. If you look at the prevalence in diabetic patients, it's 0.16%. In the renal transplant recipients, it's 1.2%. Because obviously the renal transplant patients are on immunosuppressive drugs that modulates the immune system and promotes infection. So 0.14 cases per thousand population, a mean of 65,500, 38.2% attributable deaths per year. And so when to suspect for mucormycosis? If we're very clear with the symptoms, like if a patient's presenting with sinusitis, like nasal blockage, congestion, any bloody nasal discharge is there, or is there any kind of pain on the cheek, if any facial pain, one-sided facial pain or numbness or swelling is there, if there is blackish discoloration of a bridge or nose and palate is there, if patient presents with toothache or they complain that the tooth is loosening or falling out, there is involvement of jaw is there. If you look at the involvement of eye, like there is blurred vision or double vision, then we can suspect of mucormycosis. There is definitely a SHA is definitely there, thrombosis is there, and other symptoms like chest pain, pleural effusion, hemoptysis, worsening of respiratory symptoms could be there. So hyperglycemia directly contributes to the risk of mucormycosis. There's also diabetic ketoacidosis. Diabetic ketoacidosis is basically whenever there is any kind of infection that will promote diabetic ketoacidosis. If patients not taking adequate fluid, then it will further aggravate diabetic ketoacidosis. So whenever the patients present with DKA, we have to rule out infections. That's very common in cases of DKA. DKA with mucormycosis, we have to diagnose because mucormycosis is definitely one of the lethal complications, and we must act early, act fast. It's also very challenging to treat rhinoorbital mucormycosis with intravenous amphotericin B alone because it also needs a surgical therapy, surgical curettage, combination of treatment, treating DKA with insulin, IV fluids, mucormycosis with amphotericin B. It's a complex treatment. Surgical debridement becomes mandatory as mucorals are rapidly invasive and progressive. Hyperglycation of iron sequestering proteins disrupts the normal iron sequestration. There is this pathogenesis which promotes such infection. Mucorals are rapidly invasive, it multiplies very fast, and hyperglycemia, basically high blood sugar, provides a good environment for it to grow and invade the deep tissues. So, mycotic co infection in person with COVID 19, with diabetes. Co infection with COVID 19 bacterial infections are most frequently observed, but in severe cases, we do see fungal infections. Mucormycosis, there are different forms of fungus infections which see it could be from pneumococcal group, rhizopus, rhizomucor, absidia, or apophytomycosis. Uh, we'll go with some case that uh, what to do's and don'ts during the management of mucormycosis. First thing is that we need to control blood sugar, and that also we need to control it very quickly. We need to monitor blood glucose level post COVID 19 discharge and also in diabetics because we have seen uh, like many cases who were non diabetic and after COVID 19 have turned diabetic. So, so these kind of patients we have also seen very commonly. We Since steroids is life saving COVID 19, so we can't say don't use the steroid, but use it judiciously. There should be correct timing, correct dose, and duration of it. We need to use clean, sterile water humidifiers during oxygen therapies. Use of antibiotics and antifungals should be used very judiciously. Because during the peak COVID times, we have seen that people used industrial oxygen instead of medical oxygen because there was shortage of oxygen. And there also people there is also theory that this industrial oxygen is not that much pure and it also contains impurities which may also further aggravate COVID-19 these complications like mucormycosis. What we don't have to do not miss warning signs and symptoms. All these symptoms of sinusitis, eschar formation, bloody discharge, headache, blurring of visions is very important. And we must pick these signs at a very early stage. Do not consider all the cases of blocked nose as cases of bacterial sinusitis. In cases of COVID 19, you have to diagnose it at an earlier stage. And only we can diagnose it if we'll increase our sensitivity. If we'll pick up earlier cases, even if the symptoms are of sinusitis, at least investigate, do a fungal stain of the discharge, and that will help us to get more and more people diagnosed at early stage. Do not hesitate to seek aggressive investigations and appropriate like KOH staining for microscopic culture. Fungal culture is there to detect fungal etiology. And do not lose crucial time to initiate treatment for mucormycosis. COVID 19 associated mucormycosis, the convergence of two storms. The prevalence of mucormycosis was 94% in diabetic patients. Like 100 patients who we were diagnosing with mucormycosis, out of that 94% patients had diabetes. And among poorly controlled diabetes mellitus, like 67% had a risk of COVID 19, a risk of mucormycosis. And among severe COVID 19, 95% had mucormycosis. So, typical presentation of mucormycosis in diabetic patients, mostly rhinoorbital or rhinoorbital cerebral presentation. Treating physicians should have high suspicion. Hyperglycemia control is the best strategies. Cranial facial pain without swelling can be a neuropathic pain in diabetic mellitus patients with COVID 19, and by itself, without facial asymmetry and nexuses, should not be suggestive of mucormycosis. It's a very important point because of neuropathy, which is the common thing with diabetic mellitus. Not all patients who present with craniofacial pain with swelling is because of mucormycosis. This is another study which was published in 2019. 18 patients with diabetes presented with maxillary sinusitis, and obviously this is the picture of the microscopic picture showing broad aseptate hyphae branching at right angle. This is consistent with mucous species along with dense inflammatory uh, infiltrate. This is the CT image findings showing involvement of left maxillary, ethmoid, and frontal sinuses. So, mucor viral land. Patients with moderate to severe COVID 19 are more susceptible to mucormycosis. COVID 19 infection, its treatment resulted in immunosuppression, and pre-existing comorbidities have made patients vulnerable to secondary infections, including mucormycosis. Uncontrolled diabetes and use of corticosteroids increase the risk of invasive fungal infection. We must have high index of suspicion, early diagnosis, and appropriate management. So, this guidelines for diagnosing and treatment of mucormycosis there. COVID 19 patients, if it's severe, admit into ICU. If mechanical ventilation is required, then we have to give, and we have to check for risk factors like diabetes there, is there not, use of steroids, if the patient is a transplant recipient, what's the neutrophil count? Neutropenia may aggravate mucormycosis. Then the next is investigation. Do a normal KOH culture, fungal culture, a Malditoff, or there is also molecular identification is there. If you have diagnosed a mucormycosis, then the surgical treatment is the best one to start with. We can do the primary prophylaxis with posaconazole, and the first line treatment is amphotericin B. It's always better to give the liposomal one because it has got way lesser nephrotoxicity. How to manage mucormycosis? Obviously, first thing we need to understand it's not only a physician's job or the endocrinologist's job. It's like team-based approach. We need interventions from the ENT surgeons, neurologist, dentist, and we have to work as a team. And hyperglycemia basically provides the medium for it to grow, and the mucorals spread very faster, it's very much invasive. So we have to do the surgical management first, and we have also to control blood sugar. Controlling blood sugar should be our first priority. If possible, reduce the dose of steroid. If it's not possible to reduce dose of steroid, then we have to adequately titrate the doses of insulin so that we can achieve euglycemia. Discontinue immunomodulating drugs. The patients who are on transplant, we can discontinue drugs. Extensive surgical debridements to remove all the necrotic materials. Medical treatment, like we can insert the PICC line, maintain adequate systemic hydration, start IV amphotericin B infusion, antifungal therapy for at least 4 to 6 weeks, and then we have to keep on monitoring the radiological monitoring plus hematological monitoring and looking at creatinine. If we are giving serum creatinine, we also need to look up for the serum electrolytes, and obviously the inflammatory markers like CRP, TNF alpha, IL-6, everything we need to keep monitoring. So, severe COVID 19 infections and long standing diabetic foot ulcers. This case had the sign of orbital infections were noticed only after 10 days of admission to COVID 19. Treated with broad spectrum antibiotics and steroids. One more thing, like if we are giving broad spectrum antibiotics, then also it sometimes give way to for fungus to grow because it has cleared everything for fungus, made a good environment for the fungus to grow. So we must be very careful while you're giving lots of antibiotics. All these factors tend to facilitate fungal co-infection along with any possible COVID-19 pathophysiological mechanisms. So either the previously undiagnosed mucous infections may have been aggravated or it may have subsequently developed. This is the case 1, this is the case 2. You can see this, there is the involvement of facial nerve, and you can also see the big necrotic ulcer in the hard palate. This is the black SHA which we are talking about. These two patients had uncontrolled diabetes. Main symptom was sinusitis, nasal discharge, ophthalmic changes, and facial nerve involvement. They were diagnosed with mucormycosis with microbiological testing and CT scan, and treatment with uh, achieving euglycemia with tight glycemic control, endoscopic surgeries, debridement, and antifungal therapies. This is another case, 47-year-old female with poorly controlled diabetes. They came up with diabetic ketoacidosis with suspicion of mucormycosis. There was right-sided facial swelling and pain with loss of vision. And this is the CT scan, which showed contrast showing moderate mucosal thickening. And CT venogram shows absence of enhancement in right cavernous sinus. So black necrotic debris in the nasal cavity and multiple ulcers in the hard palate was the finding. There was decreased sensation of right-sided face, absence of wrinkles, drooping of right angle of the mouth. It was all goes in favor of facial nerve palsies. So management was endoscopic sinus debridement with insulin infusion. Obviously, hydration is one of the most important part, and posaconazole 200 mg orally every 6 hours with ceftriaxone and clindamycin after septic workup. Later, the patient developed multiple brain infarcts and cerebral artery occlusion. Cavernous sinus thrombosis is one of the deadly complications associated with these things. Then is pulmonary aspergillosis and mucormycosis in the patient with COVID-19. The 79-year-old male history of diabetes and hypertension. They came with the complaints of fever, dry cough, shortness of breath. Saturation was around 92% while breathing 60 liters of oxygen. This was very high flow oxygen going on with blood pressure 154 by 78, tachycardia but no cardiac murmurs. And when we did the microbiological examination, it showed septate hyphae and conidia has Aspergillus fumigatus from bronchoalveolar lavage symptoms. Broad hyphae with right angle branching and rare septation of fungus with bowel cytology on day 19. So we need to, there's risk factors we need to understand that if there is diabetes, neutropenia, or treated with corticosteroids, we need to um, detect early these complications. So key learning point is that there is association between coronavirus and mucormycosis. Post-COVID mucormycosis is one of deadly combination. Uncontrolled diabetes mellitus and the use of corticosteroids increases the risk of invasive fungal infection. So always be aware of possibility of invasive secondary fungal infections. We need to use of therapeutic agents should be monitored, like judicious use of antibiotics, steroids, or any other modality which you want to use. You need to be much confident. You should also always suspect for its side effects also. High index of suspicion, early diagnosis, and appropriate management can improve survival in these cases. So, do you agree that the corticosteroid therapy is the only culprit in predisposing patients with diabetes having COVID 19 infections? It's something we all need to think on, that whether we can give corticosteroids, whether we can titrate this dose, or what's needed. It's all we have to think. There's also one more viruses that's very much common, that was cytomegalovirus. It also increases the acceleration of immune senescence and range of cardiovascular and metabolic disorders. Older people infected with CME display accelerated immune senescence and increased death rates. And CME may act as a negative risk factor for clinical outcomes following SARS-CoV-2 infection. So, if we compare COVID-19 in CME seropositive and in CME seronegative, what we see that there is a potential influence of CMV serostatus on clinical outcomes following SARS-CoV-2 infections. There is a potential increase in morbidity and mortality due to impaired and dysregulated SARS-CoV-2 specific immune response in CMV seropositive cases. So, does reactivation of CMV contribute to severe COVID-19 disease? This CMV 70 to 19% latent humans is there with 70 to 90% patients. That may lead to inflammation, and reactivation of CME may doubles the mortality rate. TNF alpha levels are elevated in COVID 19 patients and may provide a direct link to CMV reactivation. COVID 19 and strong reactivation of innate immune system may trigger CMV reactivation in organs such as lungs, bowel of COVID 19 patients. So, does reactivation of CMV contribute to severe COVID 19 disease? Basically, it's all about the inflammation which goes in the body because of COVID 19, and it goes in the circle. When there will be much more inflammation, it will cause immune suppression, and immune suppression will further leads on to more inflammation, and this inflammation will lead to give opportunities to various viral, bacterial, and fungal infection, and ultimately it affects the morbidity and mortality. CMV proctitis as a complication of COVID-19 with immunosuppressive treatment, and physicians should always consider the immunosuppressive risk while treating severe COVID-19 pneumonia, as severe opportunistic infections usually happen in very immunosuppressed patients and are increasingly reported. COVID 19 pneumonia, immunosuppression, and CMV activation. This is the perspective, this is the case history, and the basic thing what we need to understand is the in severe COVID 19 infection, there is a significant T cell lymphopenia along with lower natural killer cells numbers coupled with neutrophilic leukocytosis. a situation ripe for CMV activation. And further CMV activation may cause increased morbidity and mortality. So, if in a patient with COVID-19 pneumonia, peripheral neutrophilic leukocytosis is replaced by cytopenia with persistent low T cells and natural killer cells, coupled with deterioration of pneumonia, then additional causes for this complications needs to be investigated and managed. This is obvious now. We are not recommending the use of plasma, but in the beginning, plasma was one of the treatment suggested for COVID-19. So convalescent plasma, CMV infection, and persistent leukopenia in COVID-19 recovery phase. What's the link? So persistent leukopenia is high risk and severely ill cases should give rise to a suspicion of COVID-19 and cytomegalovirus infection. So, in brief, what we need to understand that if a patient comes with a leukocytosis, total leukocyte count is high, and suddenly the leukocyte count drops, then we should definitely think of these kind of viral infections. This is one of the more association of GBS, Guillain-Barré syndrome, obscured by diabetes mellitus and peripheral neuropathy, because GBS will have motor weakness, and diabetes, if there is severe diabetes, it also has its own neuropathy complications. So sometimes we may get these overlapping kind of symptoms, and it could be very confusing for our regular practice in our regular practice. But if we carefully monitor the symptoms, then we can diagnose these kind of picture at the earliest stage. In If we're suspecting for IVIG, then um, plasmapheresis and IVIGs are the two most effective treatment in cases of GBS. So COVID-19 associated with GBS obscured by diabetes mellitus, it highlights the neurological complications of SARS-CoV-2 infection, particularly in those with underlying comorbidities. Heightened suspicion of GBS in diabetic patients with reported change in baseline neuropathy after SARS-CoV-2 infection to achieve prompt diagnosis and treatment. So summary is like poor glycemic control and immunocompromised state of patients with diabetes are key risk factors for developing diabetes-associated infections. Patients with diabetes having complications are more prone to diabetes-associated infections. Post-COVID mucormycosis is a deadly addition to pandemic spectrum. Uncontrolled diabetes and use of corticosteroids increases the risk of invasive fungal infections with mucormycosis. We must have high index of suspicion, early diagnosis, and appropriate management can improve survival in patients with co-infection of COVID-19 and mucormycosis. SARS-CoV-2 infections and a strong activation of innate immune system may trigger CMV reactivation in the lungs and bowel of COVID-19 patients. And for this, awareness is one of the most important thing. Only we are aware, then only we can diagnose and treat these kind of infections. Thank you.
Uh, Pratyush, for a very informative and elaborative talk on the different aspect of infection in an immunocompromised state like diabetes, and the use of immunosuppressive drugs, the steroids and immunomodulators while treating a patient of COVID-19, and especially the reactivation of the innate immunity, which leads to the reactivation of the CMV infection, leading to severe COVID infections. So